On December 31st, 2019, Chinese authorities reported to the World Health Organization about an unidentified coronavirus-related pneumonia, which was later named coronavirus disease 2019 or COVID-19. 3 months later, the WHO declared COVID-19 a pandemic, and as of May 2022, there are over 500 million confirmed cases and 6 million confirmed deaths worldwide. Fiji is a Pacific island country located in Melanesia. In Fiji, as of May 2022, there are approximately 65,000 confirmed COVID cases and 862 confirmed deaths, latter high numbers of considering Fiji's population of 900,000. Despite Fiji's quick initial response, such as declaring state of emergency, procuring testing ability, and receiving vaccination from COVAX, thanks to the triple burden of COVID-19, non-communicable disease, and climate change, Fiji's mortality rate from COVID remained high. Additionally, due to Fiji's heavy reliance on travel and tourism, the national economy was impacted heavily by COVID restrictions. This public health and economic burden has been all the more severe for population living in the remote islands. It is clear that Fiji requires a novel solution that tackles both public health and economic burden of the next pandemic, focusing specifically on the remote island communities. Therefore, we propose a solution to improve Fiji's preparedness for the next pandemic, Fiji Islands Rapid Surveillance Taskforce, or FIRST for short. The primary objective of FIRST is to screen remote island community through rapid dispatch within the first day of disease outbreaks.
We designed FIRST to tackle four major concerns with Fiji's remote island communities: healthcare inaccessibility, risk factors, economic over-reliance, and threats of the next pandemic. To understand how to effectively tackle Fiji's pandemic vulnerability, we must first examine its geography. Fiji has four divisions: Central, Western, Northern, and Eastern. The Central and Western divisions consist of Viti Levu, the largest island in Fiji. The Northern division includes Vanua Levu, the next largest island. These two islands together are home to 87% of Fiji's population, while the other 13% inhabit remote islands, mainly in the Eastern division. This difference in population and degree of isolation translates to disparity in healthcare accessibility. Fiji's healthcare is composed of three levels of care: divisional, subdivisional hospitals, and health centers. Each of these corresponds to tertiary, secondary, and primary healthcare. In Fiji, Viti Levu has all the three tertiary hospitals, while the Eastern Division only has 3 subdivisional hospitals and ill-equipped public health centers. Therefore, not only are remote island communities distant from central tertiary hospitals, their medical accessibility is extremely low. These groups will be particularly vulnerable to disease outbreaks. Remote island communities also possess risk factors that will leave them particularly vulnerable to disease outbreaks. Because they live in remote islands, the food they can obtain is naturally very limited. As a result, their diet mainly consists of imported processed foods, leading to dietary imbalance, obesity, and diabetes mellitus. Additionally, while the low median age among these remote island communities allows majority of the population to avoid severe symptoms, the tightly knit nature of these communities allows for easy transmission to extended family members. Generally speaking, a nation with diverse sources of wealth generation is said to have a healthy economy. However, 38% of Fiji's exports is based on travel and tourism, while another 19% is related to transport. This heavy reliance on travel, tourism, and transport renders Fiji's economy particularly susceptible to disease outbreaks, as social distancing and border closure are enacted. For example, due to COVID-19 restrictions, by May 2020, nearly 50% of tourism businesses in Fiji went out of business, resulting in an annual GDP growth of negative 15.7% in 2020. Experts predict that the next pandemic will be caused by a respiratory viral disease. Due to Fiji's low median age, we predict that the overall mortality rate of this disease will be low. On the other hand, because travel, tourism, and transport constitute more than half of Fiji's exports, the economic threat posed by this disease will be substantial. Therefore, utilizing unused resources from tourist industries for early screening would alleviate the burden on Fiji's public health and economy.
FIRST is divided into 2 phases: non-emergency and emergency. The non-emergency phase includes establishment of equipment and workforce to prepare against future outbreaks. It has 2 steps: collaboration and training. The Ministry of Health will collaborate with tourist firms and local boat companies in order to establish a standing mobile screening unit system. This system will be activated during disease outbreaks when tourist businesses temporarily close but rapid screening is needed. For the next 2 years, the Ministry of Health will hold 5-day-long sessions during the summer to train nurses for remote dispatch operations. The boat rental company that would partner with the Ministry of Health will provide their boats at a discounted price. In return, the Fijian government will provide subsidies to maintain their businesses when the pandemic eventually hits Fiji. This will serve as the incentive for rental companies to join the program. For each rented boat, first we'll procure polymerase chain reaction kits, refrigerators to store samples, screening tents, and personal protective equipment. The Ministry of Health will hold internship programs, which will be available to second and third year university students majoring in biology or bioengineering. This month-long program will be held during the summer, and it will allow students to learn various lab techniques, including PCR. This training will be held regularly for 2 years to foster skilled lab technicians in Fiji. The final week of training will consist of real-life simulations. During this period, nurse and other healthcare workers will also be sent to distant islands in the Eastern Division via rented boats. There, they will be taught how to set up screening tents, make nasal swabs, store mucosal samples. Once these nurses return to the nearest subdivisional hospitals, lab technician students standing by would perform PCR tests on these samples. When there are actual reports of outbreaks in remote islands and communities, we transition to the emergency phase, made of 3 steps: dispatch, collection, and reporting. When an outbreak occurs in remote island communities, the Ministry of Health will urge boat companies to immediately dispatch their mobile testing units. Each mobile testing unit consists of a team of 4, 1 captain and 3 healthcare workers. Once they arrive on the island, they will set up a screening tent. Then, 1 worker will record each person's basic information, while the others will collect swabs and store samples. Generally, samples for PCR testing last only for a certain time at sufficiently low temperatures. Using a refrigerator that sustains temperature of 4 degrees Celsius, samples can last for 72 hours. With a speed of 12 nautical miles per hour, approximately 22 kilometers per hour, each boat can cover approximately 1,600 kilometers after a sample collection. This allows for screening in multiple islands before returning to the nearest subdivisional hospital. Subdivisional hospitals will run collected samples through PCR tests and send the results to the Ministry of Health. The ministry will then send results to each individual via text message.
For the budgeting plan, we only consider 2-year maintenance expenses for the non-emergency phase. This decision was made because there's an extremely low chance of a new pandemic striking Fiji in less than 2 years. Moreover, the government can call for the emergency phase at any time and scale up the project when necessary. We're planning to provide sufficient financial incentives to the local boat rental companies. The cost of these incentives will be the cost of maintaining and running these boats during dispatch. The program will pay $250 a day for the rental fee. In addition, to relieve the burden of maintaining their business during the pandemic, the government will pay the personnel cost of the rental company by hiring their boat captains and marine mechanics to participate in the first program. However, during non-emergency phase training, only the boat captains will be hired. Adding the food cost, rental fee, and boat captain wages required to operate the boats, it will cost a total of $100,000 over the span of 2 years. We also thought that adequate incentives must be provided to the nurses and civil servants to compensate their risk contracting the disease and traveling long distance on boats. Additionally, we allocated a budget for lab technician training and intern wage. Other equipment required to run rapid surveillance are mentioned below in this table. We have seen how a pandemic can devastate the ones in rural, remote areas of a developing country. For the next pandemic, Fiji must provide measures to protect populations in the rural islands. We believe that first plan to train lab technicians and conduct rapid surveillance by visiting remote Fijians is an effective way to improve Fiji's pandemic preparedness in remote islands.